Okay, well, welcome everybody. This is our EAHAD webinar on COVID-19 and hemophilia. I'm Mike Makris. I'm based in Sheffield in the UK. And EAHAD, for those who do not know, is the European Association for Hemophilia and Allied Disorders, which represents health professionals in Europe. For this, the next hour, we have three speakers that probably are the three speakers with the most expertise in COVID-19 and hemophilia in Europe. The first speaker is Víctor Jiménez Yuste from Madrid, and he'll be followed by Flora Peyvandi from Milan, who is the president, and finally will be Cedric Hermans. Each of the speakers will have up to a maximum of 15 minutes to give their presentation. And if you have any questions, if you go to the bottom of your screen, you can see the Q&A there, and please ask your questions through that. We've got a number of questions that have been submitted already that we're going to ask. And if you have any specific questions, please ask them, and we'll do our best to answer them in the 15 minutes at the end. So without further ado, I would like to go over to Víctor Jiménez Yuste, who is the Haemophilia Centre Director from the La Paz University Hospital in Madrid. And he's going to tell us about their experience with COVID and hemophilia.
Thanks, Mike. Thanks. I want to thank welcome everybody. I want to thank Mike for his kind invitation to be here in this webinar and for this idea to share our experience in our COVID here in Madrid. And also I want to thank also Mike and Cedric for the support to our center during the last 3 months. It has been very important for us in this moment. So when he asked me to discuss about the past, present, and future of COVID infection here in Madrid, I think it's something that when you face this kind of presentation, usually you talk about the past, talk about the last century or the last year. The past started on March, and it started March. This is the logo of our hospital, and you can see below our logo there was other 2 hospitals that are twin to our hospital, and in one of them this hospital here is a hospital dedicated mainly to ambulatory surgery, but there is a ward that dedicated only to high isolation infected patient that was participating in the Ebola crisis and also in the Crimea Congo fever, and everything started here for us. The 1st of February we have the first case imported from tourists in the Canary Island. Later we have the second, in the 10th of February we have the second case in Spain, and the 25th of February it was the first case in Spain, the Madrid, sorry. I was sent to our hospital to this unit, and this is this is a real photo of our colleagues working with the first patient. So imagine later how we have to work with the rest of the patient. But for us, for the hematology department and the hemophilia unit, everything started on the 6th of March. With only 13 patients here in this twin hospital that is in front of our complex. We discussed with the head of this unit, and he recommended us to start prevention measure and not to wait to the official recommendation. So this is why during this weekend we started to work in a program. The program was based in 2 objectives. The first one, I think, is very clear, but is to reduce the transmission of COVID-19 among our patients. And the reason is because at that moment, we don't have any evidence about the severity and the complication of a person with hemophilia. And second, to prevent the spread of the infection between us, between the healthcare workers. And the reason was mainly because we have preliminary report from China, from Italy, that there was infection among healthcare workers. So the first is it's very easy to understand measure was try to avoid that the patient arrive to the hospital only in case of emergency. Please arrive to the hospital. And then we started to create, if they have to be attended, first we create a checklist of symptoms. Initially it was only cough and fever, and we we started to work in this way. In all the entrance of our facility, we have some personnel trained to make this checklist of symptoms, to wash the hands of the patients. We have a donation for a private company with temperature taking devices, so we take the temperature, and when we are available in the initial phase, we don't have face masks. We have now recommending to use it. So the second measure, I think, was the most important, is that all the trial nurses, the study coordinator, all our investigators in the hemostasis unit, and coordinated by the head of the hemostasis unit, Dr. Alvarez, work from home. And it was very important for us because the hospital facilitates home access to the medical record. They control all our huge program of clinical trial. We have published recently in hemophilia how we deal with it. And also they have a very close contact by telephone with our patient, and they resolve clinical complications that avoid the patient attending to our center. So for us, it was a very, very important barrier between the clinic and the patient. And also they organize something that we don't have prior, is the home delivery concentrate. They were very close to the patient association, sending these factors at home. And also we start to make a register of all the complications that all of patients have, and I'm going to show you later. And finally, we send to our patient a recommendation to do exercise. So what happened after? What happened several days later? There was a full lockdown here in Spain. This is the Madrid street empty of people, and to our hospital arrived the tsunami in the next day. The tsunami means that this is the waiting room of admission department full of people with COVID infection. This is our facilities for physiotherapy full of patients, and these are photos for a newspaper here in the most important in our country that came to our hospital to do that. So this is the tsunami in our center. For the first 13 patients, we reached in the peak around 950 patients in the different facilities in our hospital, in this twin hospital, and also in the intensive care unit. It means that in some moments we have 80 to 90% of the COVID patients in our hospital. And we have to increase the number of intensive care unit beds to 3.54 times. So this is a picture, a real picture of a theater, a surgery theater, that it was converted to in a bed of intensive care unit. So what about our staff? We have to dedicate more than 50% only in COVID, in the COVID duties, and we have a rate of infection about 20% of our doctors. So it means in some moment we have only 20 to 30% in the hematology department to attend the blood bank, the oncology, bone marrow transplantation unit, and also the hemophilia department. So we were working so hard during this day. So this is the past. What about the present? The present is that this is the situation now in our country. This is the more affected areas, Madrid, and this is Barcelona. And this is also, I'm going to show you the death in our country. The death is that the peak was the 2 April with 950 deaths. And yesterday was the first day during the pandemic we have 0 deaths in Spain. Probably today we have again some cases, but we have reached 1 day with 0 cases reported to our government. So this situation in Spain, this situation in Madrid, this is the number of admissions have decreased dramatically after the full lockdown of our country. This is the same in patient in the intensive care unit. So the situation is improving. I'm going to show you in the next minute what are the results of our register. We were, as mentioned before, all our team was connected with our patient. We made connection with 346 patients with hemophilia, von Willebrand disease, carriers, and another rare bleeding disorder. And we have detected 8 patients infected with COVID with PCR positive, and another 36 patients with possible cases. It means that they have symptoms, they have probably cases, but was not confirmed by PCR. So in all our experiences, that there was a mild in all cases. We don't need to admit in any of them. In our cohort, there was 37 patients that were HIV positive. In 2 of them was infected with PCR, was infected, HIV infection. 2 of them are healthcare workers, and One of them was nimicimab prophylaxis in this patient, and also was in a clinical trial in concizumab, and he stopped because there was a stop in the trial 1 week before start the infection. So what we observe? We observe that the level of adherence was quite high in our patient, that around half of them maintained the physical activity that we recommended, and they follow the treatment that we prescribe most of our patients. In terms of it made a more stricter or not a lockdown, he made similar to the rest of the population. They have not a more strict, they have no fear about the condition of hemophilia. Around 90% was accompanied by the rest of his family, and they were able to do the daily activity during the lockdown. And this is our future. This is our future. This is the result of we have observed this that we have to cancel during this pandemic around 1/3 of our cancels. We postponed half of them, and we attended only around 4 to 5% of our patients here in the center, and around 15 of them were done by telemedicine. It means that this is the future we have to do. Around 80% we have to work in this cancel or postpone consults that we have in our center. So we have a huge work now, and we are working on dealing with this situation. So this is the present. Now, what about the future? What about the future? Now, and probably later, Cedric is going to talk about more extensive about that. We are consider all people who attend to our center as a possible case. So we maintain this check entry. Second, we have some recommendation that probably Cedric is going to discuss later about we restricted the waiting room. We have a strict schedule of consult. So we have follow some new recommendation. So what are the lessons we have learned during this pandemic? First is that the role we have test and we have the real role of telemedicine. We have been discussing during the last year about telemedicine, how to improve, how to do medicine, but we have now the opportunity to do it. And what we have observed is that we need to improve our technology. We have been working with our with the mobile telephones, with the telephones of the hospital, with the computer. We are very lucky we can work with home with VPN, but we need probably to improve more technology because telemedicine need more device, more gadgets. So we need to improve that. Second, we have improved our home delivery concentrate. I think it's a very good idea that we need to work with them. We have a restriction in the pub. So I think this is something that we have probably want to discuss with our hospital to maintain the home delivery of concentrate. And something we have observed, and this is very interesting, and also have been stressed in a paper of Valentino about telemedicine, is that there was a high rate of satisfaction in our patients. So it means that we have probably to discuss if it was only related to the pandemic or probably it's a very good idea from them. And of course, we have to work very hard in improving data collection. So we are proposing a new model that we can contact with our patient for a lot of information from home. But of course, we need to make physical examination. We need to especially we have patients with arthropathy, patients when they need to explore. So probably in the future, we have to join both methods and try to find a new model. We have to rethink things we are doing. We need to rethink about the future and to find a new model to work. And finally, I want to finish with a positive message. This is the view from my desk. I view now. This is the same. I'm gonna make a short video in the worst time of the COVID pandemic, and it was a rainy, snowing day in Madrid, and you can see few cars. It was completely locked down. Some of my colleagues and myself, we said this is like it was like a apocalyptic view of Madrid, and this is the same 3 minutes later. I made the last week from my desk, and you can see in the video that now we are changing the face. We have car. It's a sunny day, so I want to finish with a positive message. First, in terms of the evolution of the pandemic, and second, that we have the price has been very, very high. but we have learned a lot of lessons about how to deal and how to manage to cope our patient with hemophilia. So probably in the future, we can apply all these new technologies we have discovered or we have implemented during the pandemic. So thank you very much for your attention, and probably later we can discuss your question.
Thank you, Victor, for an excellent overview about what has hit you in a massive way. Those people that do not work in centers where there are a lot of COVID patients, it's difficult to comprehend the impact of what actually happened over such a short period. But probably one of the centers that was hit most in Europe, and the first one, big center, was the north of Italy. And we move over now to Professor Flora Peyvandi, who is the president of EAHAD, who is going to give us a presentation about their experience. And we've asked Flora to specifically talk to us about the issue of thrombosis. And Flora, over to you.
Thank you very much. Good afternoon to everyone. First of all, I have to thank Mike for putting together this different session and organizing the first webinar at the time of COVID. So I would try, as has been mentioned by Mike, to tell you our experience in terms of the management and how things moved on in terms of the mortality for the increased hypercoagulability and what has been done, where we are standing, and what is our opinion about that. If you can help me with the slides and put it on, I can start my presentation. Thanks very much. And the next slide is just a very basic introduction that has been shown. And as you know, it took us a few months from when China started to report the first cases in December of 2019. Unfortunately, soon in February, we started to see that there is a dissemination of infection with COVID-19, and almost more than 5.5 million people around the world now is affected, with more than 350,000 people who died from this infection. Very soon, I would say, there was very clear for the physicians who were working in this field that this COVID infection, a part of the respiratory problem and the difficulty of breath and the symptom associated to that was also some kind of a clinical picture which was not explainable at the beginning, and that was due to the alteration in the circulation of this patient. And soon it came over that there was associated with the hypercoagulable state of these patients. And the next slide is just reporting to what all of us we heard about the link between the inflammation and coagulation, but never we had such a close feeling what means the Virchow triad and how the endothelial injury could really end up with a thrombi formation. Here, the virus infection would affect the endothelial damage, and also there could be some kind of additional damage by the intravascular catheter, which ends up with the cytokine and other type of molecules that could be involved in the inflammation process in combination with the status of the patient, where they are very sick patients, especially those that they are intubated or ventilated in the reanimation and in those wards with a high intensity unit care. And in all these patients, we started to see that there is a hypercoagulable state, which was showing with the pulmonary emboli, and we were seeing in a non-usual number with the highest incidence of, I would say, deep venous thrombosis and pulmonary emboli. And I remember when at the beginning of this pandemic, we were having a chat with all the physicians, and they were just mentioning that this number are not the usual number that they are facing up. and we couldn't believe at the beginning, that there is a need for increasing the amount of the heparin. And at that time, I started immediately in our center to develop a hemostasis lab to understand what was going on. And if I can have the next slide, there was lots of discussion at that time, because the first papers, they were coming up from some of the authors in China showing that the patients affected with COVID-19, they were having a very similar situation to DIC, with thrombocytopenia, fibrin degradation product were increased, with the prolongation of PT and APTT, and in non-survivor, the fibrinogen and antithrombin level were lower. And this picture was very similar to what we call DIC. However, in our hand and in our wards, and especially in the high intensity wards, we could not see the similar situation. We were seeing only the similarity by increase of D dimers. However, we were seeing also a high level of von Willebrand factor antigen and factor VIII, but the number of the platelets were not reduced, and there was no consumption of coagulation factor, and there was no prolongation of the PT and APT. Can I have the next slide? So now the question, which I think is still unsolved, and we are all working on that. How comes that the similar infection with the same virus could give a different picture, which would be very important for us, also for our decision in terms of prophylaxis and treatment? Why the data from China were absolutely similar to DIC, but the European and North American data are seeing the DIC only in a few cases, and most of the cases they are not having the DIC? Is it a different disease? Is it a different strain of virus? Or just because we knew better what was happening, and we started the treatment of the patient with heparin sooner compared to our Chinese colleague, and that's the reason why we didn't end up to DIC. And that's our type of investigation ongoing right now. Next slide. And here, to make a summary of what is happening, we think all the conditions that I mentioned by virus infection, particularly at the long endothelial level, end up with the storm of the cytokine and with the inflammation first as a local inflammation and then as a systemic inflammation, creating a activation of coagulation by involvement of the platelet and ending to the thromboinflammation COVID-19 associated, which is called CAC, which differs from DIC. And in next slide, I was just trying to see what is available in terms of data in different labs or from post-mortem studies. And if you see, there are few post-mortem studies that clearly are showing the presence of pulmonary emboli and microthrombi in alveolar capillaries and thrombotic macroangiopathy as a deep venous thrombosis, and that are these kind of conditions that are causing the death of the patient. And in some of the papers recently, we have also seen the activation of angiogenesis. So if you look on the patient who are at the ICU, we can see even that the mortality of these patients are increased from 20 to 40, even to 70% in some cases due to the DVT and pulmonary embolism. So what we have to do, how we have to treat the patient, and what type of lesson we have learned. Do we need to use the heparin? How much we have to use it? And I tried to put together the data available in the literature and come up with some kind of conclusion which might evolve in the next months due to more knowledge regarding this particular condition. But this is the state of the art where we are standing right now. The next slide. What about the arterial events? We have also seen some of the arterial kind of thrombosis, like at CNS level with a stroke. And if you have data that arterial events are less frequent than VTE, but still with a significant increase in the incidence compared to the previous year. So that, that area is still not completely clear, and we need more investigation regarding that. And I have to confess also, the use of the heparin, especially intermediate and high dosage of heparin at some point and some patients, led to the event of the massive bleeding, and is very, very important how to analyze the data available and understanding what is the safety and efficacy and the benefit of the usage of heparin, and which the dosage of anticoagulant should be done and used. And next slide. Okay, so let's start with the data available, putting together what we have to do with inpatient, outpatient. So the first message is regarding those patients that are only positive for the test of COVID. This kind of patient, they do not need, even the general population, when the results are positive without any sign of and symptoms of inflammatory condition or thrombosis, they do not need any kind of prophylaxis. And we are talking about the patient that they are inpatient, and in those we need to make a daily evaluation of coagulation, testing eventually for the DVT with a compression ultrasound, and for the pulmonary emboli, and to look whether there is the difficulty of breath and the respiratory distress syndrome that they can have is not due only to the problem of the ventilation, but also due to the formation of the clot and the circulation. So that's the reason why you might want the VQ scan and having a more detailed information in the circulation of the lungs bilaterally. The next slide, as I said, is just trying to make in this pyramid the classification of the patients from a simple person who get positive, who get infection, but without any sign and symptom, which is a blue color, up to the top of this picture when there is a COVID patient with a severe symptoms that end up to the mortality and the death of the patient. Of course, the orange and the red part are the most severe patients, and unfortunately, which could end to the death. These kind of patients are very severe and needs a particular attention in terms of evaluation and in terms of the prophylaxis. And sometimes we might need, I will show you, to increase the amount of the heparin and make it suitable, individualized based on the symptom and the severity of the clinical manifestation of the patient. And next slide is just trying to report with this table all data that has been released from different society: Italian, CZ, International Society of Thrombosis and Hemostasis, NIH, American Society of Hematology, ACC, and all together. So at the, if I have to make a short summary, all societies, they agree that patient who is symptomatic with COVID needs to have the prophylactic dose with heparin. For the non-hospitalized patient, we need only to make the treatment if the patient did have a history of DVT and is at a high risk of thrombosis, and there is a sign and symptoms, and there is some kind of markers that's showing the activation of coagulation. Next slide is just discussing a little bit more whether there are some patients would require a higher doses of heparin. And there is a controversy data in literature. For example, Italian and European, there are more positive for individualized type of heparin usage, even with the intermediate and higher dose when is needed, and also ISTH. However, ASH and NIH are requiring a more, I would say, evidence-based data, clinical trial, randomized clinical trial data. And what about the after hospital discharge? I would say the data regarding this point is very, very preliminary, and there is no enough data in our hand. And also some of the society, they are continuing the treatment for 14 days, and they observing the situation also with the other markers and trying to follow up the patient and look for the eventual management of the patients if is needed, even for the longer. Next slide. So the management for the full dose is similar to what has been reported with all the society. You make the full dose only in those cases that they are symptomatic, like the DVT and pulmonary emboli, and if there is a sudden deterioration of the patients. Next slide is just trying to show how management of the patients could be difficult, because a part of heparin, you need to understand when and where and which dosage and what type of drug to use as an anti-inflammatory and for the protection of the endothelial cells and as an antiviral, and all together trying to cool down the inflammation, not ending to the activation of coagulation. And next slide. This is our experience, and we tried, I will bring in this slide our dosages that we have used at some point when the number of the pulmonary emboli were jumping up, and 30% of our intensive care unit patients were having the problem of thrombosis. We did use 3 different dosage with a low intensity, intermediate, and high intensity, and this strategy really changed the mortality in our hand and reduced by 60 to 70%. This data is not published yet, but submitted, and I hope you can have the possibility to read it in the future. And next slide. About clinical trial, as I showed, ASH and NIH is waiting for the result of clinical trial. There are 27 studies ongoing, but fortunately, or unfortunately, I would say fortunately, the patients with COVID are getting less and less, and I'm not sure that this clinical trial will end up with a very clear picture with a randomized clinical trial of how we have to use the anticoagulant therapy. So the data that I brought, I think, is just telling us every patient with a symptomatic type of COVID-19 needs the prophylaxis, and if the clinical condition is getting deteriorated, we might want to consider higher dosage of the treatment with heparin. And next slide is just ending, I think, my presentation. You can see in the left side, there are the first picture in the middle when we were opening the COVID-19, and in the right side, after 3 months, 2 months and a half, you can see my doctors, they are more relaxed, as Victor was showing. Fortunately, the numbers even here are getting much less, and we closed the COVID ward, and now after COVID, there is a huge issue of how follow up the patient and how to take care of the rest of the patient. And I want to thank all of my physicians and nurses for doing the amazing job that they had done in the last 3 months. And I want to thank you and Mike for listening and organizing this session. Thank you.
Thank you very much, Flora. Great experience shared with us. And our next speaker is Cedric, who is going to share his experience about the COVID-19 and hemophilia, and probably touch on the issues raised by both Victor and Flora, and about anticoagulating patients with hemophilia. Cedric, over to you.
Thank you, Mike. Thank you for the invitation to share some more information about the clinical care of hemophilia during the COVID pandemic. So this is a very basic slide summarizing the impact of COVID-19 on hemophilia care in our center, as well as in many centers across Europe. Clearly, as Victor emphasized, we had to totally reorganize our activities by canceling face-to-face review clinics, by canceling scheduled surgeries that could be postponed, and also we had to stop inclusion in clinical trials. Despite this, we did our best to maintain contact with all, at least our severe patients, by telephone, by emails, and we tried to inform these patients about the key precautions. At the same time, we had to manage patients with hemophilia A and B who had to be admitted in our center. So this is a slide summarizing clearly the role of the Hemophilia Treatment Center during the pandemic. Clearly, information of patients is critical in my view. We know that the hemophilia community has been confronted with viruses for several decades, but this one is different. And also it has nothing to do with HCV, HIV. And also it has nothing to do with the viral vectors that are currently using for gene therapy. We also try to make sure that we could ensure supply, avoid shortages of concentrate. We used to liaise very regularly with other teams in the hospital who were involved in the management of our patient. Very rapidly, we realized that it was important to collect and to document all the cases. So we spent a lot of our time on this. Psychological support was also needed for some of our patients. At the same time, we tried to make sure that all acute medical or surgical non-COVID related problems were well identified without major delay and were properly managed. And that was sometimes a bit of a challenge. One of the issues is certainly the management of concentrate. Well, honestly, I cannot complain too much. I live in a country that has been investing in hemophilia care for many decades. So most of our patients are on recombinant factor VIII, factor IX prophylactically. And the good news is that most of our patients do have a lot of supply at home. Although there is no formal program of home delivery, I have to admit that it was not a major problem during the crisis, since most of our patients could easily have access to concentrate. So what did we do during the pandemic? We tried to make sure to keep regular contacts with the patients, especially the problematic patients that we took care to identify very carefully. We tried to convince our patients not to change their treatment regimen in terms of over or underuse. We tried to avoid any shortage of concentrate, especially in the hospital where patients had to be admitted. We had regular contacts with the wards and the intensive care unit. And also, we kept regular contacts with our different partners from the industry based here in Brussels to ensure that there was no problem with availability of stock and logistics of delivery. Before going more in depth regarding the management of our patient, I would like to share this clinical observation with us. This is one of our patients who was admitted in mid-March, age 54, severe hemophilia, no inhibitor. He was on prophylactic treatment with EHL factor VIII. And unfortunately, these patients had several risk factors: obesity, major obesity, diabetes, and poorly controlled hypertension. This patient was admitted with a fever for several days and shortness of breath. And very rapidly, the diagnosis of COVID-19 was confirmed. The nasal swab was clearly positive, and the CT scan disclosed typical images of severe COVID. The patient was initially admitted in internal medicine, and we were involved daily. He was maintained on prophylaxis with his factor VIII, received oxygen, and also the infectiologist decided that he should be on hydroxychloroquine. I'm not sure this decision would still be the same today. So what happened to him on day 3? Unfortunately, he had to be admitted in ICU, require intubation and ventilation, mechanical ventilation. And at that time, it was clear that a more intensive replacement therapy was needed. So we continue with the same EHL delivered by continuous infusion, approximately 200 units per hour, aiming at factor VIII level between 80 and 100%. Very quickly, he was on low molecular weight heparin. I have to stress the fact that at this stage of the pandemic, it was not as clear as today that this patient should be on low molecular weight heparin. So initially, he was treated with a low dose, and the dose was rapidly increased because of recurrent episode of atrial fibrillation. During his stay, there was no clinical evidence of thrombotic or bleeding complication. And you can see the D-dimers level that were achieved in this patient, reached in this patient up to 7,000. The anti-TLA was carefully monitored, and the creatinine clearance was markedly increased. Very unfortunately, this patient died on day 23 from septic shock. And the postmortem did not reveal any thrombotic or bleeding complication. Based on this and other observations, myself and some of my colleagues in the hospital from different departments, we decided that it would be useful to provide some guidance, and that was summarized in the paper that was recently published in Hemophilia and is freely available on the Wiley website. So this is clearly to emphasize the fact that patients with hemophilia are not at greater risk of infections with COVID. And there is no evidence at this stage that patients with congenital hemophilia are more likely to develop more severe COVID-19. This patient was really unfortunate, but I have to emphasize that he had several risk factors. It's clear that patients with hemophilia should follow the same precaution with respect to their disease management. And it's also clear that hemophilia will impact on the management of patients who need to be admitted in hospital, and that was clear for all patients. What about the admission in intensive care of patients with COVID-19? Well, it's important to emphasize that hemophilia does not represent a contraindication to admission in ICU, mechanical ventilation, and other invasive procedures. But what is clear is that if we want to do this, and if this is needed, correction of factor 8, factor 9, ideally, in my view, by continuous infusion, bringing factor 8, factor 9 in normal range or close to normal range to prevent bleeding complication is important. You have to combine this with a careful biological monitoring. You should make sure, especially for patients with arthropathy, that they do not develop nerve compression. Thromboprophylaxis is, in my view, needed unless if contraindicated. Patients could be enrolled in clinical trials. And I don't have experience with ECMO, and I do not know whether patients with hemophilia have had ECMO so far in the frame of these pandemics, but this is, in my view, totally achievable. Let's make sure that these patients do not develop acquired von Willebrand factor deficiency. Another issue that Flora elegantly reviewed already is the issue of COVID-19 coagulopathy. And clearly, COVID-19 coagulopathy mainly results in thrombosis, thrombotic complications, and a new entity, mainly thromboinflammation inside the lung, with a formation in the lung of some microthrombi. Some patients might develop bleeding complication, only the few patients who develop severe DIC with a very advanced disease. What's the impact of hemophilia on the management of this patient? Well, clearly this is quite complex. And although myself, the faculty, and most of you listening to us today have a major understanding of this, well, it's quite difficult to manage. These patients are at risk of bleeding complications, spontaneous or iatrogenic, but are also at risk of thrombotic complications, VTE, pulmonary microthrombi, catheter thrombosis. So in my view, it's clear that these patients do require hemostatic treatment, but to what extent do they require antithrombotic treatment too? This is a quite difficult question. Flora already reviewed with you the impact of COVID-19 on the blood test. Well, for patients with hemophilia, just want to emphasize the fact that the APTT will be prolonged, but it will be corrected depending on the substitution with factor 8, factor 9. Let's not forget that patients with hemophilia B might reach very high levels of factor 8, and let's not forget that patients on emicizumab will have very short APTT. Platelet count, fibrinogen should not be different. What about the D-dimers? Well, the D-dimers clearly appear as a very useful diagnostic tool to evaluate the COVID-19 coagulopathy. What do we know about D-dimers in patients with hemophilia? Well, there is no much information. I don't think that the D-dimer are significantly affected by hemophilia, but we need to be cautious. There is some unpublished evidence that EMI in itself does not impact on the D-dimers levels, but that could be different in patients who have bleed, in inflammation, or on bypassing agents, or using rebalancing agents. I'll come back to that. So this is a quite busy slide showing how problematic and difficult can be the management of these patients with hemophilia admitted in ICU. In my view, they require thromboprophylaxis, and they also require substitution. I don't have much time to go through all the details, and I have to emphasize that all the information on this slide has never been validated. What I would say is that depending on the status of the patients, I would aim for levels of factor 8, factor 9 above 30% if the patient is on the wards, but I would be a little bit more aggressive, even really aggressive if the patient is in ICU. And regarding low molecular heparin, I think a classical prophylactic dose should be given on the ward, but if the patient is in ICU, I would double the dose. And if the patient has thrombotic complication, honestly, we do not know how frequently that has been or that could be, I would go for a therapeutic dose. There is another question about the potential difference between hemophilia A and B. Well, clearly in patients with hemophilia B, the factor 8 levels could reach very high levels. We know that in non-hemophiliac patients, factor 8 levels can be dramatically high, up to 300–400%. In patients with hemophilia B, these patients could also reach very high levels. And honestly, we do not know what this impact would be on thrombin generations and the risk of thrombosis. So the question is open: should we treat less aggressively patients with hemophilia B, severe hemophilia B, and COVID-19? Another scenario that is increasingly possible is having a patient on emicizumab developing COVID-19 and admitted to hospital. So how should we manage this patient? Well, I need to remind you that emicizumab has a very long half-life, so I don't think it's needed to stop the treatment because there will be a long-term effect. What I would do is, if the patient is on the ward, I would give low-molecular heparin. If the patient is in ICU, well, I would add factor VIII to emicizumab, and I would thromboprophylaxis patients more or less aggressively, depending on the setting. But again, I have to emphasize that this is not yet validated. What about even more complex situation is the patients with hemophilia on these new agents that rebalance coagulation, I mean anti-TFPI and fitusiran. So many of these agents are currently being validated in phase 3 clinical trials. Some of these trials have been paused because of thrombotic complication. There is very limited evidence regarding the diagnosis and management of COVID-19 in patients on these agents, but let's be more or less optimistic, since there are people who have knowledge and much more knowledge than us. These are people involved in the pharmacovigilance of these trials, the medical monitors, the experts running these trials, and they should certainly be consulted and provide advice. Well, clearly, what could we say? Well, if you have a patient on anti-TFPI or with very low levels of antithrombin, because antithrombin generation has been inhibited, well, clearly these patients are, in my view, at increased risk of thrombosis. This thrombotic tendency is probably exacerbated by the COVID-19 coagulopathy, but again, this is pure speculation, but this is quite complex to evaluate. This is quite complex to reverse and control. Do these patients need low-molecular heparin? And on the other side, these patients are at risk of bleed, but the risk of bleed is reduced by the rebalancing agents, but we don't have a lot of experience. It's totally unpredictable and difficult to evaluate. So do these patients need factor VIII? Do they need factor IX? When and how much? These are, again, many open questions. And again, this is a purely speculative slide that I prepared this weekend when getting ready for this webinar. And clearly, if you have a patient on anti-TFPI, I think that most of us would agree that I would pause it. I would stop it transiently. I would probably give low dose factor VIII at the beginning and then probably escalate. And I would give low molecular heparin. But again, little evidence to support this. The future will tell us, and experts should agree on this. To finish, the two last slides, the last one is probably of interest. This is one of our patients who was admitted with Hemophilia B that had been treated with gene therapy and who developed COVID-19. Honestly, we were quite disappointed when these patients were admitted. You can understand, 65 years of age, severe Hemophilia B, efficiently treated with gene therapy in November last year, did not require steroids, was not on steroids, no cardiovascular risk factors, and factor IX after gene therapy between 23 and 27. Well, clearly a very nice story. And then these patients got admitted with COVID-19, typical symptoms, quick confirmation of the diagnosis. But the good news is that the CRP remained low. The factor IX even increased slightly during the infection. D-dimers were not that elevated, slightly above normal. Fibrinogen not significantly increased. We did not use thromboprophylaxis. The patient was discharged after 7 days. He fully recovered and he has developed antibodies. To conclude, well, I think there are some potential positive impacts and lessons from this pandemic. Certainly the promotion of self and home treatment and telemedicine, the importance of the new treatment, the awareness of the importance of managing and treating efficiently the comorbidities, the regular follow-up in the treatment centers. I think the treatment centers are quite of importance in this kind of major problem, and also promote independence of humanitarian aid program, especially for countries that do not invest a lot or cannot invest a lot in hemophilia treatment. This is my last slide, and I thank you for your attention.
Thank you very much, Cedric. So we've got 10 minutes for questions and answers. And I mean, perhaps all the speakers can come onto the screen. thank you to some of the speakers who've realized they could answer the questions that were asked specifically to them already. But there was one question that was the one that's come out more frequently, and that was actually partially answered by all three of you, but I'll discuss it again. The question was about patients on emicizumab and whether have any of you have seen any problems that with these patients during the pandemic?
We haven't had any problem with the emicizumab during the pandemic in our patients.
Thank you. Victor?
We have only one case that was infected, and he had a mild, very mild disease without pneumonia, and we treat with low molecular weight heparin doses, prophylactic doses, till he was PCR negative, and it do very well.
Okay, thank you. Cedric?
Well, a single case, a very mild disease, managed at home without any complication, so, and did not receive thromboprophylaxis at all.
Okay. Our very first question, right at the start, was from Mexico, and the question was whether are you reopening your hemophilia centers? What is the status just at the moment of your hemophilia centers? Are you physically seeing patients, or are you still continuing to do telephone consultations?
I could start to say that we opened by 30%. We always were doing our activity for emergency 24 hours a day night, and now 30% of the checkup started from this month.
Okay.
Yeah, we are also reopening, but in a very slow way, because we are still in a very early phase of the end of the pandemic. So we are probably 2 weeks or 3 weeks delayed from Milan. So we are opening very slowly, and we have some plans to evaluate every week in order of the evolution of the cases, and probably we plan to have a total or partial or more than now at the end of June.
Well, and in Brussels, it's nearly back to normal. We try to, have a daily clinic, seeing more and more patients. We also test every of our patients for antibodies. That's what we do. But this is our local practice, just to know what happened to them, and since the tests are available.
Okay, thank you. There was well, actually, following up from this question, I'm going to ask you to speculate going forward. Do you think there is going to be a second wave, or are we over it for good now? I mean, obviously, it's impossible to know. And I've also got a second question specifically from Flora, because yesterday in the news in the UK, there was loads of exposure to a clinician from Milan who felt that COVID-19 is now not the same disease as it was 2 months ago. And he was speculating that it was more mild disease. So perhaps we can ask you, Flora, about this issue, about this. Is it a milder disease? And then speculate about the long term.
There was a lot of discussion in the last, I would say from 14, 15 of April, we are seeing the patient in emergency with much less severe clinical manifestation. And most of the cases are found because we are obliged to make the testing. Otherwise, the patient at least doesn't look to have COVID-19 and they are coming for some other reason. Saying that, I'm not sure whether pneumonia is the only symptom of the COVID-19, and that's something else we need to investigate and to see what is the endothelial activation in this patient. Regarding what has been said by this doctor, very Berlusconi styles from San Raffaello Hospital, so that was certainly that this physician talked, and I think every physician who is working with COVID know that the situation is changing, but there are two possibilities. First, this is a different strain of the virus. Virus is changing, is evolving, is mutating, or because we are only seeing those patients that are asymptomatic or very, very mild that we were not able to see it in the first wave because we were full of the very severe cases. I think that's two possibilities. For doing that, we need to have lots of data on virology, and we haven't. Unfortunately, sequences is very too small, still too small.
What's been your experiences? Victor?
I agree with Flora, because also we see yesterday in our TV the virologist from Milan, so it was also a news in our TV. Everywhere, I think every Europe, and but we discussed with our colleagues in the that are now treating this patient, and they say the same, have the same feeling of Flora. The new cases are mild cases. We are not seeing this severe, and I'm not a specialist in virology, so I couldn't speculate about that. But I agree with Flora in the real fact that we are seeing less severe cases. There are less cases, but also less severe. And I agree with her. It's a phenomenon that we don't see in the past, or it's the real nature of the virus. I don't know, but the fact is, this is the fact.
Cedric?
Well, probably I'm a little bit more skeptical. I think that when people will start mixing again with large number of people, that means, on the beaches, on the planes, in the airports, in the train station, or, during parties, I think, the problem could come back. No, we have created, totally independent communities, and clearly the virus doesn't like that. So we have been able to eradicate, but once people will start mixing again, I think that could restart. But I don't have any expertise. It's just gut feeling.
It will be interesting to see what will happen in the United States now with all the demonstrations. That is really exactly what you do not want, during a pandemic, to have huge numbers of persons very close to each other, especially ones that are of higher susceptibility.
Correct.
One of the big things that has happened that I've seen is obviously all of these trials in COVID-19 patients, and the one that affects us as hematologists is obviously the anticoagulation. Flora, you mentioned your study about the benefit. I presume it's an observational study.
Yeah. This is actually a cohort of, at some point, as I was mentioning, the number of the thrombotic events were really too high. And I got in touch with Fritz Rosendahl to say how we have to manage, and do we have to make the randomized, and we end up with this is not ethical anymore, and we have to increase the amount. We were not sure what would be the number of the bleeding. Then I talked with Ida Martinelli, and we have started actually our data on the prospective data on increased amount of heparin, as I showed, and really the results are fantastic. I mean, was fantastic. We decreased significantly the number of mortality. We will see if the paper would be published. You have the data in detail.
One of the issues is the problem with all of these. We all set up clinical trials, but the numbers have suddenly plummeted so much. And the question is whether any of the clinical trials on venous thrombosis treatment and prophylaxis that are randomized will ever be completed if there is no major second.
Yeah, I doubt, to be honest, because, for example, some of the countries, the number are increasing. For example, in India, I was reading the number is increasing. Unfortunately, the data in India seems that they're much less symptomatic, and the symptoms are much mild. And of course, you don't need to increase the amount of heparin in those populations.
Okay, we've reached the top of the hour. I thought it was 3 excellent presentations, and I thought it was very worthwhile doing. We had a great number of participants, and I'm sure this is recorded, so it will be on the EAHAD website. On behalf of myself, all the speakers, and on behalf of EAHAD, thank you all for joining us for this afternoon. And have a good day.
Bye-bye.
Thank
you. Bye-bye. Bye-bye. Thank you. Thank you. Bye-bye.